Dr. Rader, thank you so much for joining us on MD Newsline. Can you please introduce yourself to our audience?
Thanks for this opportunity. My name is Dr. Ryan Rader. I'm a clinical assistant professor at the University of Kansas Cancer Center. I work at a community site at the Lee Summit, Missouri location, where I predominantly see patients with breast cancer. I also am a board certified hematologist and oncologist, so I can see a myriad of patients, but I'm very privileged to have a very active breast cancer patient part of my population.
Mhm. And breast cancer is always a hot topic, and recently there have been some talk about trends. So please let me know, what trends are you seeing in the clinical presentation of breast cancer, specifically among younger and premenopausal patients?
Yeah, so unfortunately, and we see in data from the CDC as well as anecdotally in my own patient practice, I'm seeing more and more patients that are presenting at younger and younger ages, even in their 20s. Women who have breast cancer at young age, defined as less than 45 years of age, unfortunately have a more aggressive phenotype. And by phenotype, what I mean is um, when I treat breast cancer as a medical oncologist, that means I deal with treatments like chemotherapy, endocrine therapy, targeted therapy, treatments that affect the whole body. When I see a patient with breast cancer, the main thing that I'm looking at in order to help direct treatment is what is driving this breast cancer. So when we do a biopsy of breast cancer, we're looking to see, is there estrogen receptors present on the breast cancer tissue? Are there progesterone receptors? And then a protein that's called HER2 that's normally expressed on breast tissue but can be hijacked in the growth of breast cancer cells. And so the estrogen, progesterone, and HER2 statuses are critically important for optimal treatments. We see more patients that have more aggressive signatures for those. So triple negative breast cancers that don't have estrogen, progesterone, HER2, or that are HER2 positive. Which generally are known to be more aggressive, but we have made tremendous advancements in the treatments of HER2 positive breast cancer across all stages. So, unfortunately, we are seeing an increased uptick about 1% per year in patients in that demographic with new diagnoses of breast cancer year over year.
And with these kind of this new crop of patient types that seem to be going up year after year, in your experience, which initial signs or symptoms tend to make early breast cancer diagnosis more challenging in everyday practice?
So, breast cancer screening is critically important in the early diagnosis of breast cancer. And current guidelines vary depending on which organization, but essentially, starting at age 40, unless you have increased risk factors, the general population's recommendation is to start mammograms at 40. And so, a lot of women, when they're in their 30s or 20s, are detecting this with palpable masses. And what can be challenging is oftentimes women that are premenopausal can have fibrocystic changes of the breast, so they can notice changes in their breast tissue. They can notice, lumpy, bumpy breasts. Then that can come and go with their cycles. So it's the masses that come and stick around that can be disconcerting and should definitely be a warning sign to get that evaluated by your healthcare provider.
And when it comes to things like mammography, ultrasound, and MRI, and evaluating patients, what are your thoughts when it comes to suspected breast cancer across different age groups and risk profiles? Is there one method that works better for a certain group versus another?
Yeah. So mammograms, although uncomfortable, I've been told, are definitely the gold standard when it comes to the diagnosis of breast cancer. People think that MRIs are better, and MRIs certainly have their utility, but mammograms are so important because they especially can be used to detect tiny areas of calcification. They also can be used to look when you have mammograms done over a period of time to look to see if there are slow changes. And by detecting those slow changes earlier and pointing those out and getting biopsies done, mammograms remain the gold standard and they are what is needed for screening. However, um, as we've advanced, we do have other types of imaging modalities. Ultrasounds can be helpful, especially in patients who have dense breasts. So the FDA recently, in the last couple of years, mandated that the density of breasts be reported on every mammogram. And for those that have dense breasts, supplemental imaging with things like ultrasound can be helpful to detect things um, uh, that are of concern that might not have been identified on mammograms. Um, Breast MRIs can also have a utility. Um, Oftentimes, you're plugging patient's characteristics into risk calculators like the Tyrer-Cuzick model. And if you meet a certain threshold, or you have other criteria like you have a known BRCA1, BRCA2 mutation, or if you say have a history of Hodgkin's lymphoma and you've received mantle radiation, these are all risk factors that can significantly increase risks for breast cancer. And so in high risk clinics across the US and other locations, having that breast MRI can be helpful, and more closer than once a year monitoring to look for early signs of breast cancer in those higher than average risk patients.
And where do things like molecular and genomic assays fit into your routine practice for early stage disease? And how do they influence decisions about systemic therapy?
So it's exciting times in the treatment of breast cancer, and it feels like there are new treatment options that come up every quarter, which is why going to conferences and staying abreast of current literature allows me to provide my patients with the best care that we have in 2026. Genomic assays have helped tailor um, how we offer adjuvant chemotherapy, so chemotherapy after surgery, in select patients. So the most common subtype of breast cancer is those that are hormone receptor driven, those estrogen, progesterone expressed cancers that do not have HER2 positive disease either. So in those patients, especially if they're lymph node negative and depending on patient characteristics, if they're fit enough to receive chemotherapy, these scores, like the 21 gene recurrence assay known as Oncotype, and there are others as well, can help um, direct the aggressiveness of the tumor, and B, how much benefit there could be from giving chemotherapy. So when it comes to chemotherapy selection, having these genomic assays is helpful. There's also in the national guidelines, like the NCCN guidelines, recommendations for the again those type of population, hormone positive, HER2 negative, with the breast cancer index that can help inform benefit of extended endocrine therapy, so beyond 5 years. So these are tools that I use every day in practice.
Mhm. And in which clinical situations are you most likely to consider advanced tools like as circulating tumor DNA or other liquid biopsy approaches, even as they're still evolving?
Yeah. So this is a area of active interest and ongoing research. Areas in which I currently use guideline directed ctDNA monitoring is in my patients with stage 4 or metastatic breast cancer, especially again in that hormone receptor positive, HER2 negative population. When I have patients that are on first or second line endocrine therapy, there can be acquired mutations that arise that allow for more opportunities for other directed agents. So keeping an eye on those when I at times of which I need to consider changing treatments is very helpful. We have ongoing research and studies that have shown if you're doing chemotherapy before surgery and you have ctDNA positivity noted in blood work, and if you get the treatment and then you go to surgery and you become ctDNA negative, that can lead to better prognosis. However, ctDNA in the adjuvant setting, so the stage 1, 2, or 3 setting, has not been shown in evidence and is not currently recommended outside of clinical trials to be commonly used. So it's a very, very, very common question I get in practice. And I believe that tests need utility and they need to be able to inform my practice. And I certainly hope, as I continue moving forward, that there will be a study that shows that if we're able to detect things earlier with maybe ctDNA positivity, I can do something about it, change treatment, give additional chemotherapy, and then it goes away. And that shows that patients can live longer. I certainly would be fully supportive and hopeful that one day that study will exist.
And are there any reoccurring points in the diagnostic pathway where you see opportunities to streamline or clarify workup for busy clinicians?
So I think the challenge that I can face that I would want to educate other healthcare providers on is um, the involvement of medical oncology early on in the treatment of breast cancer. There are certain subtypes of breast cancer, like the triple negative breast cancers and the HER2 positive breast cancers, where depending on size, stage, other patient characteristics, they may benefit from chemotherapy or other treatments before receiving surgery, because how that treatment affects the disease at time of surgery informs how I treat them afterwards. So say a patient has a HER2 positive breast cancer and I over 2 centimeters, I'm oftentimes recommending a combination of chemotherapy and immunotherapy with anti-HER2 drugs. And if at time of surgery all the breast cancer cells are gone, which is called a pathologic complete response, I go down one particular treatment pathway. If there's still remaining breast cancer cells after that treatment, I go down a different pathway that I wouldn't have had access to had we gone to surgery first. And I'm not saying that every patient like that needs these treatments up front, but deserve informed conversations prior to surgery.
Mm. And when you first meet a newly diagnosed patient, what are the key factors that guide your choice between neoadjuvant and adjuvant systemic therapy?
Oftentimes, the decisions are made for me by the subtypes, the estrogen, progesterone, and HER2 expression. Um, I also appreciate very much my surgical colleagues, because there may be some surgical factors that go into whether or not they're eligible for surgery right now or not, or where the tumor exists, if it's close to the pectoralis muscle, or, other findings, things like that. If I know that they're going to need these treatments one way or another, and if I can provide better surgical outcomes by doing those treatments up front, I think that that's an important consideration. Sometimes having a multidisciplinary discussion is always going to be helpful to inform those decisions, because it's really a team effort when it comes to the treatment of breast cancer.
And how are you incorporating targeted agents like CDK4/6 inhibitors, PARP inhibitors, and antibody drug conjugates in your current treatment algorithms for different breast cancer subtypes?
I can do an entire lecture just on that question alone, and it's exciting. And all of these studies are coming out that are constantly challenging the current treatment paradigms for cancers of all types are being affected almost on a monthly basis, it seems at times. So, CDK4/6 inhibitors work to slow down cell cycle growth, and for decades, the treatment of the hormone receptor positive, HER2 negative, especially stage 2 to stage 3 patients generally, has been hormone blocking treatments. Since Monarch-E, which was a study that looked at adjuvant abemaciclib, one of the CDK4/6 inhibitors, showed improvement in patients not having their disease come back. I'm routinely incorporating CDK4/6 inhibitors in this space, not only abemaciclib, but also ribociclib as well. PARP inhibitors can be used in select patients that have BRCA1/2 mutations across all stages, except for stage 1. And then antibody drug conjugates are something that we've been routinely using in the stage 4 or metastatic setting, but recently, just in October of 2025, have found a benefit in select patients with HER2 positive disease that remains after neoadjuvant treatment, especially if they're lymph node positive. We're starting to see antibody drug conjugates being used earlier and earlier, and them to have more benefit across a variety of cases compared to traditional chemotherapy.
And what is your approach to positioning immunotherapy in triple negative breast cancer, and how do you frame patient selection in practice?
So, Keynote 522 has been a study that revolutionized the way that we treat stage 2 and stage 3 triple negative breast cancer. Um, Routinely, the mainstay for these patients was neoadjuvant chemotherapy, and then Keynote 522 layered in pembrolizumab on top of that immunotherapy agent. So I'm oftentimes looking at immunotherapy plus chemotherapy in the neoadjuvant setting in my patients that have more than 2 centimeters of triple negative breast cancer or have evidence of lymph node involvement. There are ongoing studies to determine, can we leverage that pembrolizumab and be able to give less chemotherapy and still have non-inferior outcomes. And so this is exciting times, and including a clinical trial that we have going on at the University of Kansas Cancer Center, looking at um, certain characteristics and seeing if we can find a way to deliver less chemotherapy and have similar outcomes.
Interesting. And for patients with metastatic disease, how do you balance disease control, toxicity, and quality of life when planning long term treatment strategies?
Yeah. Um, Stage 4 metastatic breast cancer in 2026 is unfortunately uh, an incurable disease. That being said, it can become a chronic disease, and of critical importance is balancing potential toxicities with um, extending patients' lives. These are very difficult conversations to have at time because it requires being honest with the patients and telling them, I will remind them that I have lots of treatment options and continue with clinical trials and with new advancements to have more tools in my toolbox to help combat this disease. However, I want to make sure that as I extend their life, that the quality of life that they have is meaningful, because patients will often talk to me when it's not that, and then we have to reevaluate. So it's about having open lines of communication, asking patients for their opinions, and also making sure that their quality of life is what they want it to be, because if it's not, then having the ability to adjust that, lower doses, consider switching treatments, taking treatment breaks are all things that I've used, because it's quality of life is incredibly important.
And especially with younger patients, how are you approaching conversations about prognosis and reoccurrence risk in a way that's both honest and supportive?
Yeah. Um, it is of utmost importance to be honest with your patients. That's every time. Patients don't want information withheld from them. They don't want this to be sugar coated. They would rather prefer to leverage, because this is for many of them the first time they're going through this. They're looking for information. They're looking for guidance, because it's a scary time when your body is, going through this cancer phase, this cancer diagnosis. So just sitting down, saying, this is what I have, this is the best evidence, these are the numbers that I deal with, and this is what I think makes the most sense for your treatment. Um, Making sure that all their questions are addressed to the best of your abilities, and making sure that they feel comfortable with asking these information to make the best decisions for them.
And like you mentioned earlier, there's a lot of news that comes out about breast cancer all the time. And especially when you have younger patients or more savvy patients that are looking for information. So I'm wondering, when there are several clinically reasonable options, what communication strategies are you using to help you align the treatment plan with a patient's preferences and their life circumstances?
So, um, I'm very privileged that the vast majority of my practice is breast cancer. And so I enjoy being able to sit down with a patient, if I'm seeing them for a second opinion or for a first opinion, and telling them that 95% of what I do is breast cancer. It's important to give them the information that is known in current literature, and also sometimes we have two reasonable treatments that are not directly compared head to head. You talk about the risks and benefits of both. Also, especially with new diagnoses or when changes of treatment need to be made, being evaluated at centers that have access to clinical trials is vitally important too, because not only are we looking for new drugs or new combination of drugs, we're also looking, we have a lot more de-escalation studies. Do we need to do all these things? And so these are things that happen at the onset or when we need to make treatments, and not halfway through. So making sure you're feeling confident with the treatment plan before moving forward is important.
And are there any specific techniques or tools that you found useful for improving understanding and adherence during complex multi-modality treatment courses?
It's a good question. Um, Long gone are the days where patients just show up and listen to the doctor and just do whatever the doctor says. I honestly am very appreciative of my patients. We're in the 21st century now. Information is prevalent. It is okay to be informed. It is okay to ask questions. It is okay to do your own research. That research must be taken with a grain of salt, because not everything that you read on the internet is accurate. And I wish that we could purport to say we could do differing treatments that don't have the same placebo controlled, evidence based medicine that has less side effects. I'd be first on the block to use those, but I have to rely on evidence based medicine based couched in good science and has been shown to have a benefit. And so when I approach patients when they have questions about differing strategies and things like that, being able to say, this is what I know and this is what the literature shows and I know and I can prove it. And we have hundreds, if not thousands of patients on some of these studies and can be able to show with very fine granularity to the best of my ability how outcomes go for those patients.
And at what point in the trajectory do you like to introduce the conversation about survivorship and survivorship planning? Do you communicate that alongside active treatment discussions? How does that normally go?
So, patients, depending on the type of treatment that they've had, are potentially at higher risk of other conditions outside of cancer that should be taken into consideration. Patients on endocrine therapy should be working with their primary care provider, making sure that their blood pressure is under control, they don't develop diabetes, that their cholesterol is under reasonable control. Those are risk factors that we can look for and mitigate to the best of our abilities. In my older patients, who are on aromatase inhibitors, something that I watch very closely is their bone health because bone density, uh, osteopenia, or osteoporosis is not something that one can feel. And so oftentimes the first sign of osteoporosis is a compression fracture or a fracture of a bone that shouldn't have broken from, routine, a fall that's our bones are only as strong as they can be. And so at some, if you're in a car accident, that those bones can break, but looking and monitoring and addressing things like osteoporosis before it reaches that point to mitigate our risks as much as possible is
Mhm.
important. But survivorship should be, it's a collaborative effort and it's about focusing not only on the breast cancer, but the patient as a whole.
Mhm. And now I want to talk about something that we don't often hear about, but we know life goes on during breast cancer, before breast cancer, after breast cancer. And there's pregnancy associated breast cancer, which people don't often address, but very much exists. So, can you define pregnancy associated breast cancer in your practice? And what kinds of presentations should clinicians keep in mind during pregnancy and the postpartum period?
So, pregnancy associated breast cancer is any breast cancer diagnosed during pregnancy and up to a year of the in the postpartum stage. Um, we have limitations on, mammograms are not recommended routinely when women are pregnant due to risk of radiation exposure. And so, over 80% of the time, breast cancers that occur during pregnancy are felt as a palpable mass. And um, the bodies are going through changes, obviously, as you go through pregnancy. And so, you're unfamiliar with as breasts grow as a result of hormone changes during pregnancy. So women particularly need to be attuned to that and monitoring and making sure that these masses are noted earlier and can be assessed safely with screening modalities like ultrasounds that can be used to detect things and can be safely biopsied with needles. But, um, it is an uncommon um, characteristic in women. It's rare, but when you look at women under the age of 35, over 15% of patients that have breast cancer are diagnosed with pregnancy associated. So higher in those younger patients. So they definitely need to be conscientious in monitoring for that.
And which imaging and biopsy approaches do you consider most appropriate and safe when evaluating breast symptoms in a pregnant patient? And are there any that patients should be advocating for themselves, particularly?
What I'd say is every patient is different, and this approach should be done in a multidisciplinary fashion with the medical oncologist, with the surgeons, and also with the maternal fetal medicine specialists. It really takes a team to figure out timing and safety for all of these interventions. So, ultrasounds are non invasive, do not have any radiation exposure. Um, but many of the other options that we have are limited in pregnancy. Um, you can do mammograms with abdominal X-ray shielding to help decrease the radiation exposure below what is concerning for exposure for fetus. Um, if there are concerns like back pain, you can do an MRI of the spine without contrast. This is not something that needs to be done for every single patient, but if you have symptoms and you're worried about, can be done with minimal exposure to baby. And then also, you can do a right upper quadrant ultrasound to look with best abilities to look in the liver to make sure that there's no areas there. But each of these are possible, but needs to be done in a multidisciplinary fashion and individualized to patient.
And kind of along those same lines, after prognosis, how do you approach and structure treatment planning to balance maternal, status and fetal safety, including decisions around surgery, systemic therapy, and the timing of all of that?
Yeah. So a lot of this hinges on, again, a multidisciplinary conversation with the surgeon and with the maternal fetal medicine specialist and the medical oncologist. A lot of it hinges on a few factors. One, which trimester are we in? And two, the wishes of the patient should absolutely be taken into consideration. And three, again, looking at the estrogen receptor, progesterone receptor, and HER2 expression. We know and have a fair amount of safety data with certain regimens for chemotherapy, and have been safely been able to use those treatments while awaiting for hopefully as close to a full term viable pregnancy as possible. There are certain treatments that are contraindicated in pregnancy. Um, Things just like hormone blocking pills are not safe during pregnancy. If radiation is needed, that needs to wait until after pregnancy. There is limited safety data with the immunotherapy like pembrolizumab in this space, but when you're treating a patient with breast cancer, um, sometimes surgery goes first. But if you're looking and doing a lumpectomy, which is a partial breast removal, you have to factor that timing into where radiation can be safely given. And so if there's going to be a prolonged period of time in between those two, maybe doing some other treatments and waiting before doing surgery would make sense. But so much of this is individualized, and also while we're doing these treatments, making sure that the MFM team is closely monitoring
Mm-hmm.
babies to make sure that baby is continuing to do well as well as mom.
And especially with younger patients and you seeing more younger patients, what are some of the main points you cover when counseling patients about fertility preservation, future pregnancy, and even breastfeeding after treatment for breast cancer?
So, in non pregnant patients who are young, who desire um, options and discussion about maintaining future fertility options, there are things that can be done prior to initiation of chemotherapy because chemotherapy can increase rates of infertility. Um, Meeting with a reproductive endocrinologist in a timely manner is very important because there can be egg retrieval and other interventions that can be done prior to administration of chemotherapy, and those conversations are important. In addition, during chemotherapy, there can be medications given called GnRH agonists like serolin that can work to shut down, do ovarian suppression and it has been shown to decrease rates of infertility while you're on chemotherapy.
And just kind of looking into the future, are there any emerging data or practice changes that you think will eventually or significantly impact how we diagnose or manage breast cancer in the next few years?
Next few months, these I very much enjoy being at an academic institution where I get to educate fellows and medical students and residents because there are constantly studies that are changing the practice of medicine. There are constantly new drugs across all different subtypes. And um, both the challenging and wonderful thing about breast cancer is so many of these patients, regardless of what stage, are often being followed 4 years, which means these trials, in order for them to mature to show data, need to be followed 4 years. So there are a variety of studies we're always awaiting for the final results on or for interim results that are being released at conferences so that we can give our patients the best care that we have, and that will continue for many years to come.
And if you could leave listeners with one practical consideration to keep in mind when encountering complex or atypical breast cancer cases, what would it be?
Patients know their bodies better than anyone. If they are feeling something that's abnormal, it is never wrong to go and address it. It is unfortunate sometimes we catch cases of breast cancer where people have, for one reason or another, could it be financial restraints? Could it be time restraints? Could it be, worries about what this could be? And we can catch breast cancers in more advanced stages. The more advanced stages, the less likely I am to be able to cure this. So being mindful of your body, and when you notice changes, to let someone know to do those investigations, do those mammograms, do those ultrasounds.
Wonderful. Well, it's been a pleasure talking to you, Dr. Rader. Thank you so much for joining us on MD Newsline.
I appreciate your time. Thank you so much.